Hello and welcome to today's program. I'm Lori Smetanka. I am the Executive Director of the National Consumer Voice for Quality Long-Term Care. Next slide, Libby. We're glad you can be with us today. Today we're talking about nursing home visitation, focusing on new guidance that was released earlier this week from the Centers for Medicare and Medicaid Services. Next slide, please. We're pleased to have with us today Evan Shulman, who's the Director of the Division of Nursing Homes at CMS, and we'll also be hearing from Jocelyn Bogdan and Robin Grant from the Consumer Voice. Next slide, Libby, please. So it's been a year since the COVID-19 pandemic changed all of our lives, and for those living in nursing homes, the toll has been especially tragic. Not only have approximately 1/3 of all deaths from COVID been residents and staff of nursing homes, it's more than 130,000 people, but many more have suffered and died from isolation and neglect. We wanted to take a moment today because it's been 1 year since the pandemic hit the world actually, and also since there's been so much suffering over the past year, that we wanted to take a moment to remember those who have been lost this past year. And we're going to take just a few moments of silence and to see some of the pictures of people we've lost this year. Libby, can you start the slide? We received numerous photos and messages from families. You saw just a selection of them on the slide just now, remembering and honoring their loved ones. And with their permission, we are sharing them with you and sharing them also on our website. Next slide, Libby. You can visit our website to not only see some of the pictures and the remembrances of those who have been lost or remembered this year, but also you can hear a new dialogue that we recently did, facilitated by Dr. Susan Weary, with 2 nursing home residents who talk about their experience over the last year. We think it's definitely worth listening to, and we hope that you'll take the time to listen to it. And the link on the slide you see right now has the link to that program, and we'll be sharing it in the chat also during the program. Next slide, please. So our original plan for today was to mark the 1-year point of the lockdown on long-term care facilities, whereby access to residents and the facilities themselves have been severely restricted, and to have a day of action to raise the voices of residents and families and to call on policymakers to lift the lockdown in a safe way. We at the Consumer Voice, like a lot of you, have been advocating for a return to safe, responsible visitation practices that would give residents access to those they have relied on most for supports. On Wednesday of this past week, the Centers for Medicare and Medicaid Services, the federal agency that regulates nursing homes, issued new guidance on visitation. The new guidance, which went into effect immediately, makes important steps forward in reuniting residents and families. So we thought it was important to shift gears for today and share with you an overview of the guidance and be able to ask some questions about it. So we are very, very appreciative to have with us Evan Shulman, who, as I mentioned before, is the Director of the Division of Nursing Homes at CMS. He is going to review the guidance, then we'll be asking him some questions about it and giving some thoughts about it as well. So welcome, Evan. Thank you so much for taking the time to be here, and I will turn it over to you.
Thank you, Lori, and it's a pleasure to speak with all of you today. Good afternoon to those on the East Coast. Good morning to those not on Eastern Time. This is a very critical and important issue that we absolutely would jump at the chance to talk with you all. I think the beginning of this call is really appropriate because it's so disheartening, the lives that have been lost. But I think I've said this before, the second most heartbreaking thing about this pandemic, right after deaths, is the toll that the separation has taken on residents and their families. So it's right there up there with the deaths. And in fact, I think nothing is a better example of that than what I have heard from residents and their families, of some of them actually saying, I would actually rather die of COVID than go longer without seeing my family. So I think that really speaks to how close how close this is and how important this is, how close it is to being as important, if not just as almost as important, if not as important as the deaths. Again, I really appreciate the opportunity to talk with you here today. I'm going to walk through just some of the high level pieces of the guidance that were released. I assume that the Consumer Voice is very adept at getting out the link to it if they haven't already. I'm sure they can. I'm just going to walk through some of the sections and the important pieces of it, and more than just what's in the words, try to explain some of the intent and what we're really trying to get at with some of the guidance here. And really all of this starts with the encouraging signs that we're seeing throughout the country, which is that cases of COVID-19 amongst nursing home residents and staff has literally plummeted. It has really just dropped since over the last several weeks. And yes, a large factor is the vaccine that has been widely distributed. And we think that that is a huge factor. But as we've seen with COVID-19, it is typically never any one factor that leads to either drops in cases or increases in cases. It's a multifactorial environment. So there are some other things that we need to consider as we move forward, but at a high level, we are extremely encouraged by the drop in cases, and we are also encouraged by the percentage of residents that appear to be getting vaccinated. And even more so, we're excited about what this could mean for in the future. So along with that, in our memo, we start out by reiterating what we call the core principles of COVID-19 infection prevention. And this really remained unchanged from our previous guidance that was released on September 17th. And look, folks, these are the things that you all know. This is the hand hygiene, this is the face covering, this is social distancing, this is making sure that you're staying home if you feel sick, and also for facilities to take the appropriate actions. So these are all the things that you not only hear us talk about in the nursing home space, but that you hear other government officials and other public health agencies speak to. That makes it so important. So when I talk about that, it's not just the vaccine that drives cases down. These are the things I'm talking about, that it's the combination of the vaccine and all the things that we need to keep on doing in order to prevent the transmission of COVID-19. So, continue to do those. We then in the memo go over outdoor visitation. Really, we haven't changed much with regard to our guidance for outdoor visitation. We think it can really just be conducted almost all the time. Of course, there could be some weather conditions that make it difficult. And some facilities have become creative in getting around some of those weather conditions. And of course, it's also difficult if residents, just due to their condition, cannot go outside. But generally speaking, because of the increased space and airflow, outdoor visitation is preferred. But I think where we're going to talk about next is really on indoor visitation, which is really what we wanted to increase as much as possible. Because of, again, there are other factors that make it sometimes that can sometimes hinder a facility's ability to conduct outdoor visits. And also there's a certain amount of privacy that comes with indoor visits and convenience, of course. So we really wanted to maximize as much indoor visitation as we could. And in doing so, I just want to go back to something that Lori mentioned, which is that we believe that these are safe and responsible ways to enable indoor visitation. So it's not just an opening of the doors. That we think that what we've put forth here are really safe and responsible ways. And there's really, I think, 3 categories of major changes that we have put forth in the indoor visitation guidance. And they revolve around visiting when the level of COVID in the community surrounding the nursing home is high. Second would be allowing visitation when the level of when there is COVID, an outbreak in the facility. And third is really more on the personal visitation and one-on-one visitation, what we can do there to make those potentially more intimate. On the first piece of when the facility in the community around the facility has high COVID cases, one thing to remember is that what studies have shown for nursing homes is that they are greatly impacted by the community surrounding them. So a lot of the research articles that you'll see, you will likely find that the number one factor that predicts a higher risk of COVID getting in and spreading around a nursing home is the level of COVID-19 that's around the community. And there's different ways to measure this. There's the county positivity rate, which I think most people are familiar with. There's been other ways. There's the COVID cases per 100,000 residents. There's also some hospitalization rates that people look at, but we tend to focus on county positivity. It's what we've started with, and I think it's what we've continued with, and we're going to continue to focus on this. So because that the risk of COVID getting into the nursing home increases based on the evidence of the rate of COVID in the community, we still are concerned, and the evidence it shows us we should be concerned that if the level of COVID-19 in the community is high, we should be more cautious with some types of indoor visitation. However, we also recognize the efficacy, the wonderful efficacy of these vaccines. So we don't think, though, that the level of COVID-19 in the community should really impact a vaccinated resident's ability to have visitation. But what we are concerned about is those that are unvaccinated. So what we say in the guidance is that if the positivity rate in the county that the nursing home resides in is greater than 10%, and the percentage of residents that are vaccinated in the facility is less than 70%, then only vaccinated residents should have visitation, and unvaccinated residents should not have visitation. And again, a good reason for that is that's 30% of the population in that facility then is at greater risk. And as you all know, COVID-19 poses a much higher risk for severe infection and mortality for nursing home residents. And that's why it's really important that we take some extra precaution here amongst unvaccinated residents. So that's on the first part. And again, the rationale behind that is, as we've seen through all the studies, it's the level of COVID in the surrounding community that really does increase the risk of COVID in the facility. The second area is when there's an outbreak. Now, an outbreak is defined as actually when there's no case in the facility, then all of a sudden you have a case. An outbreak is not defined as if that case came directly from the hospital. So if someone is transferred from the hospital to a facility that doesn't have COVID, that would not constitute an outbreak. An outbreak is really when a new case pops up in a nursing home of a resident or a staff that was previously COVID-free. And what that means is that we have to be very, very careful here, because that means that we're not exactly sure where the infection came from. So we need to be sure that COVID is contained. As you know, facilities they have they have different structures. There's different wings, different units, and what we're really concerned about here is that because COVID spreads through so many people asymptomatically, that we're very concerned that if there are unvaccinated residents throughout the facility, if the virus is not contained, it could place many of those unvaccinated residents and staff too at risk. So what we're trying to get at here in our outbreak guidance for visitation is, look, if a case pops up, you don't have to pause everything for 14 days. That's what the previous guidance says. We don't think we need to go that far, but we do need to know that the cases of COVID are isolated. We need to know that the entire facility and all the unvaccinated residents and staff are not at higher risk for COVID. And the way we do that is through doing one round, which would take around 3 days or so, could be shorter, could be a little bit longer, one round of what's called outbreak testing, where everyone, residents, staff, everyone is tested for COVID. And if the results of that test reveal that the outbreak is really just contained to one person or even a few people, but just in one area of the facility, then really visitation can occur in all those other areas. And we believe that can be done safely. So we think that this is, again, a safe and responsible way to ensure that visitation still occurs in spite of COVID actually being in the building. But there are some limitations that we do need to put on it because of the risk that COVID places to the health of unvaccinated residents in particular. So that's a little bit about the intent and the background and the rationale for where we landed with indoor visitation. You know, one thing I want to say just about visitation and the risk and why there still is a risk, I want to mention some just high level things that we all need to remember here. And number one, there are still unvaccinated residents, and we still have an obligation to protect them. And the staff, you know, really, we owe it to staff to make sure that we reduce their risk for COVID too. So even though your loved one is vaccinated, your loved one's roommate may not be vaccinated, or the person across the hall may not be vaccinated. It could be because they chose to, which is their right. It also could be because they entered the facility afterwards. But there are still unvaccinated residents in facilities. And the second thing is that we need to remember that there are new variants out there. The data is still coming in, the information is still coming in, but we don't know for sure how the vaccine reacts and protects against all these variants. So far, we're not hearing anything that would cause us to change direction, but like everything with COVID-19, we've been learning things along the way. The other thing to remember is that while we know the vaccine prevents severe infection, which is great, which is exactly what you would want from a COVID-19 vaccine. You would want someone who takes it to be prevented from getting really sick or dying, and that's what it does. What we don't know is if the vaccine prevents someone from transmitting it. So someone who is vaccinated may not get sick, but they still may, we're still looking at this, they still may be able to transmit it. So that puts other people who are unvaccinated at risk. So we need to remember that just because someone is vaccinated doesn't mean they can't transmit it. And when you consider that nursing homes, as you know, they have a lot of turnover in some cases in nursing homes. So you could have entire units, so especially in the short stay area, completely have new residents all the way within 30 days. And even more, sometimes there are some nursing homes that have 10, 15, 20 new admissions a day or in a week. So we have to be very careful here because, as an example, someone could have a vaccinated roommate today, but tomorrow they could have an unvaccinated roommate. So when you put all these things together, we have to be very careful about how we proceed here. All that said, we think that we've struck a good balance between allowing much more visitation, but also taking into consideration that safe and responsible approach to it. The last thing I want to talk about when it comes to indoor visitation is personal touch, and I think we talk about this in the memo. There is no substitute for we don't say it in these words, but there's no substitute for a hug from mom or dad or sister or family or friend. There's just no substitute. You can be in a room with someone, but that warm embrace is just something that you cannot replace. And we do acknowledge that. And therefore we say that if a resident is fully vaccinated, then they can choose to have close contact, including touch. Now, one of the questions we've received is that, well, does the visitor also have to be vaccinated? And we actually are comfortable saying no, the visitor does not need to be vaccinated. But please remember, everyone, you really need to keep your masks on, do hand hygiene before and after, and certainly do not practice physical distancing from all other residents and all the staff in the facility. This is really just between a resident and their visitor. And we still recommend that it be done for a period of time and not prolonged. I think you can read the literature that suggests that the longer the exposure to COVID-19, the more chances it has to spread. So try to keep it short, folks. But we do have a lane here for that personal touch, and I hope that you all safely recognize this lane, and so when you are doing it, you're being cautious. So that's the main parts about the changes to indoor visitation. We also we didn't change much in our section related to compassionate care visits. However, we did reiterate that compassionate care visits can really happen at all times. They really should, right? These are visits that a significant change has happened. We have said now, not just in the previous memo, but in previous frequently asked questions documents, we said, look, compassionate care, it's person-centered. It's not just for residents who are on hospice. It's not just for residents who are in end-of-life scenarios, which, by the way, could be people that are not on hospice. You don't have to enroll in hospice, although it's a great program. It could be, it's based on the individual's needs. So we go through some examples. It could be someone who has been in the facility for a long time and now is having a struggling with the change with having not seen their family in a very long time, and also perhaps maybe has had a change in condition. But look, it could also be someone that was just admitted to a nursing home. And this is a massive change for them. They used to perhaps live with their family or live close to their family. And even if they didn't, they were in a different environment. Now they're in an environment that is foreign to them. And this is a big change. So compassionate care visits, we can't here at CMS define every type of compassionate care visit that needs to occur. We do need families and facilities to work together on this. We are not going to be the arbiters of what is considered a compassionate care visit or not. You really need to work together, which I know sometimes can be difficult. But also remember that facilities are trying to work out compassionate care visits with every resident in their facility. So it's not, so, they have to be able to allow visitation in, but they also have to be able to adhere to the core principles of infection prevention. So that's a long way of saying in that when we're talking about compassionate care, it's allowed all the time. There are factors that need to be considered, such as other residents and other residents' visitors. And that goes for all types of visits. So we do say in the memo that facilities really need to monitor how the visits are occurring, and they may want to start scheduling visitors because of the number of visitors that are present in the facility at one time. I think a great example is that it would be better for facilities to schedule visits for roommates to happen at different times, so you don't have so many people in the room. So facilities really need to look at their structure and where they're conducting visitation. Some facilities have visitation rooms, some have them in other designated areas. So there are, just because this says that indoor visitation can occur, there are some parameters that we all need to adhere to, again, to maintain those core principles of infection prevention and control, and to protect those that are still not vaccinated, and to prevent the spread of COVID-19. A couple of things I want to mention here that I think we also feel are very important. If you are not familiar with how to contact your long-term care ombudsman, please, I'm sure the folks at Consumer Voice can help you with that. I think there's a link on their website, but these are great resources for individuals who may be struggling with how to interpret some of our guidance, which, is admittedly sometimes very complex because it's a complex environment. So really encourage you to reach out to your long-term care ombudsman. And these individuals do, under federal law, have access to residents. So those are, just a great resource for you guys. And then I think the last thing I'll mention is just communal activities and dining. We didn't really need to change much here in this memo, because when it comes to communal activities, everything that we've previously recommended still remains recommended, which is if you're going to do activities, then please mask up, watch your distance, bring hand sanitizer, use as much, follow the COVID-19 principles of infection prevention as much as possible. Now, of course, with dining, you can't wear a mask when you're dining, but still, please, adhere to those, the physical distancing. And I'll give you, we received a question, hey, can more than 2 residents or families sit at a table? And the answer is, well, it depends how big the table is. So you really need to just make sure that you're adhering to all the other core principles of infection prevention while you're dining. But we, of course, have to admit that you can't wear a face covering while you're eating, and that is also noted in the memo. So I think this is probably a good place to stop and solicit questions. And I'm happy to, I think, Jocelyn, I'm going to turn it back to you. And thank you. I have a couple of things that I will probably end with, if that's all right, when we're done with questions. But for now, I'm happy to take some questions. Jocelyn?
Sure. Thanks, Evan. And we really appreciate you taking the time to walk us through the guidance. I think everyone was excited to see revised guidance and is really hoping that it helps the residents who, as you acknowledged, have really borne the brunt of the pandemic over this past year. We've heard from residents who have already emailed us saying they're very hopeful that this guidance means they'll be able to reunite with their families and ensure that they'll have the support that they need and that they had before the pandemic. And so we just want to ask a few preliminary questions that we have. I'm sure we will have more in the future. And we also want to encourage everyone listening to continue putting the questions you have in the Q&A box. I know most people are already doing that. We are not going to open up to those questions today because of timing, but Consumer Voice is going to review all those questions and try to address them in the future, whether in a webinar or another format. And I think a lot of the things that I've seen pop up in the Q&A box actually will be addressed by some of the questions that we're going to focus on right now. So the first question we want to ask, and this is a pretty big one, is around enforcement. This guidance looks like a huge step forward in many ways. And as we look through the guidance, we see a lot of language suggesting what facilities should do. A lot of what they should do is really helpful for residents and their loved ones. I want to note that the September 17th guidance was also good in many ways for the time and circumstances we were living in last fall. We now know that many facilities, though, simply chose not to follow that guidance. And when residents and families sought help enforcing it, they often found themselves at dead ends, that there was no enforcement. That guidance really left a lot of room for discretion on the part of facilities. By stating now that facilities should allow indoor visitation at all times for all residents except for these few specific circumstances, and we completely agree that safety and all of that is a factor here, but does this leave any room for enforcement if they don't? Is CMS planning to enforce this guidance, and what do you recommend families do to seek that enforcement?
Thanks. This is a great question, and we get this a lot. I think there's a few things to consider. First, when it comes to whether we can say should or must, we here at CMS, we have to adhere to all of the same authorities that are given to us that every other agency has. And really what that means is that unless federal law or federal regulation is explicit about something, then we can't say in some of our policy memos, which don't go through the same process that some of these more formal regulations and rules and of course laws do, but we can't say must. So one thing to explain is that there is just a factual line between what is in regulation and what is in guidance that we cannot cross because we don't have the authority to. When it comes to should versus must, I think one way to think about it is we are saying that all things considered, these are what facilities should do to be compliant. And there are some other considerations that are out there that could that they could do to still be compliant, but because the regulations don't specifically say you must do this, we can't say it in a policy memo like this. With that said, though, there needs to be some justification. So I want to go back to something you said that the time was different. I think you mentioned back in September. I think that we all have to remember that after we released the September 17th guidance, cases skyrocketed throughout the country following the October time. And certainly I remember after, I think the data bears this out, after the end of October, after Halloween and then going into the holiday season, cases throughout nursing homes in the country skyrocketed. And so that makes it that there is the facilities and states do have some discretion on restricting visitation for reasonable clinical health and safety reasons. That could be very specific to an area within a state, or such as if a state's hospital capacity is maxed out. That's not really considered in our guidance, but that is a reasonable health and safety risk. So there are some considerations. I will say, though, that we are in a very different place right now. than where we were after we released the previous guidance. So we are looking to, of course, enforce a resident's right to have visitation, and the reasonable health and safety risks, we would have to say, are much different than what they were back in the September and October and November, certainly in December timeframe. So I think we're in a different place. And the reason why some things may have seemed different back then is because cases were skyrocketing, which they are not now. We will continue to look at this, and we're going to continue to try to make sure that a resident's right to visitation is adhered to. One thing I would caution all of you on is that this requires some changes in not only policies and procedures for a facility, but also for states and also education amongst staff. I'll just give you an example. We received an email around 8:15 Thursday morning that's from a resident that says, my facility didn't let me in this morning. And my first response was, well, we just dropped the thing at 4 p.m. the night before. I mean, they still probably need to read it. These facilities and states, they need to absorb it, and they will need to change their documents, their policies. They'll need to educate staff. There are some things that really are not things that can change on a dime. For example, we say that you have to monitor, you can allow visitation in high positivity counties if your resident vaccination rate is over 70%. Some facilities will need to say, okay, now we're going to have to, stay on top of monitoring they should be already, but, have a more formalized way of monitoring our resident vaccination rate. So there are reasonable things that states and facilities need to do to implement this guidance. Once we're past like a few days or a week or so of reasonableness, then yeah, we expect this to be implemented. And if not, then please first off reach out to your state agency and find out why. What is the reasonable health and safety risk? And then if you're still not getting a clear answer, then certainly you could reach out to the CMS location. And of course, we here at CMS are also willing to take it. So I hope that explains a little bit about the difference between must and should, and also the difference between what was then and what is now.
Thanks. Yeah, I mean, I think in general, there have been a lot of issues even before, and I realize the situation before was very different with having those adequate safety reasons. A lot of times facilities just didn't offer anything and there wasn't much done. But to move on, our next question, somewhat similarly, it deals with state implementation. How will CMS respond, or will CMS respond if states refuse to implement the new guidance? We know this was a problem with the older guidance, and we've already heard about some states. We had a family member email this morning talking about Washington State, saying that their restrictions are much more, they're stricter, and so they plan to ignore this. What will CMS do when states refuse, if states refuse to implement the guidance?
Right. Again, we just dropped the thing a little bit over a day ago. We would love to hear so we believe states need a little bit of time to absorb the information. And then we would love to hear specifics which would be things that are, specifically from a state. We'd love to hear specifics, and that can be referred to your CMS location. And also here to us, it's at CMS Central Office, and then we can take it from there. So I don't have a comment on what we will actually do because we're still evaluating the situation. But for now, it starts with fact gathering, and again, having a reasonable understanding that when we just put out a document that does require substantial activity to absorb and implement within a state. So I'm not saying that they need some unreasonable amount of time to do it, and they should be working on it right now, but it's also not an instantaneous thing. So we need to just give them a few days.
Okay, that makes sense. And I think, yeah, we are thinking about the bigger picture as things move forward. My next question is a little bit long. It's really important, so bear with me. We can all acknowledge the level of isolation and neglect that residents have suffered this year. As I said before, and as you have acknowledged, these are the people who have borne the biggest brunt of this pandemic. Both because of COVID itself, but also because of the impact of the visitation ban. And I know we're all really hoping that this guidance will make a difference to everyone. We know that within the guidance, and you referred to this a little bit, facilities can schedule visits and limit the timing of them. And we know there are family members right now who have actually been able to access indoor visitation, but they end up with 30 minutes of visitation every few weeks because of the scheduling. We also know that in this new guidance, outdoor visitation is greatly preferred, and that residents who share rooms are discouraged from having visitors in their rooms. There are many residents out there who we all know need more than just a hug or an outdoor visit from their families. They need multiple visits each week where their family members can assist and ensure their basic needs are being met. And with staffing issues in so many facilities, we know that those needs have not been met this year. And I know that in many cases, these families want to turn to compassionate care. And you discussed that a bit already, and they should turn to compassionate care when their loved ones have experienced physical and emotional declines. But as you acknowledged, we're all aware of how difficult it can be for some residents to have their loved ones receive these compassionate care visits. Residents who have lost enormous amounts of weight, residents who have suffered severe mental declines. We know that facilities, again, just take a lot of discretion in approving these visits. And even when they do get approved, they often don't provide the frequency that's really needed to help these residents to the extent they need. And that's despite the guidance saying that those visits need to be person-centered. So my question is, for those residents, for the ones who need frequent indoor visitation, whose families desperately want to be there, helping ensure that they're fed and cared for, whose needs are not currently being met by staff, and we know, I think a lot of the family members on this call, can attest to, there are a lot of people like that out there. These are residents who need indoor visits that aren't limited in time or frequency. Where can they look, and what do you suggest they look to in this guidance to have those kind of very necessary visits?
Well, I see on the screen here you're talking about essential support person. Is that
yes? So I know that's something that we at Consumer Voice have pushed for. I know that is not stated anywhere in the guidance. I know that some people look to the fact that indoor guidance is opening up as a potential way to provide that, but because facilities are able to schedule that doesn't mean facilities are just going to schedule an hour here and an hour there. Some facilities really may space these visits out, and those family members still might not get that support. Is that something people should be pushing for under compassionate care? Should they be saying, I need compassionate care visitation every day? So what should people do if the biggest issue here is really the isolation and neglect that people are suffering? How can this guidance help them? Where should they look to for that help?
Right. Okay, I'll try to address it in a few ways. One, on compassionate care, while we can't describe, as I mentioned earlier, every type of compassionate care visit that occurs, and when they occur, they really weren't intended to be routine visits. They're really intended to be more ad hoc or infrequent visits. And I'll come back to that in a minute. The other thing that you're touching on is when residents need these assistance with support, and I've seen some comments here about residents losing weight and these individuals, family members really want to help their residents. we have a very fine line to walk here, because what you're talking about are really the job of the facility. I'm not saying that they're always doing that job. But what I'm saying is that we can't and we should not supplant the job of a facility by doing it ourselves. That doesn't mean that you're precluded from doing it, but it introduces other risks. And if someone is concerned about their loved one because they're losing weight, or there's been other changes, then they really need to reach out to the state agency and report this and have it as a complaint, so that the state can triage it and then potentially investigate it as appropriate. When it comes to essential caregivers, we actually do talk about it in our guidance, and we understand that that some states and facilities have designated categories as visitors, such as essential caregivers, and we don't distinguish between these types of visitors and other visitors. And the reason for that is because in federal law and federal regulation, there is no distinction between types of visitors. So we don't really even have the authority to deem someone an essential caregiver. But just moving past our authority or not, what the law and regulation are really trying to get at is that every resident has the same right to visitation as every resident. Just because someone has an essential caregiver, or someone may be an essential caregiver under some criteria that's designed by a facility or a state, from a federal perspective, that person has no more right to visit a resident who doesn't have someone like that, but maybe is in town and wants to visit for the first time. The resident rights span all of that. And when it comes to essential caregivers, I hear what you're saying about these individuals, they want to go into the facility and help the resident. And I've seen some other things like, every resident should be able to have one essential caregiver that should be able to go into the facility at any point in time. And I think the thing that I struggle with that, even outside of our regulatory and statutory barriers, is that if every resident has an essential caregiver at all times, that is essentially all visitation. And then our infection prevention and control risk just goes way up. So we have to be, so it's really a balance between what is under our authority and also what's realistic for preventing infections and COVID from spreading, such as if everyone has these caregivers in place, then we're really not doing our part to make sure that we're not inadvertently having COVID transmit amongst residents. And then again, I think we want to be careful. We encourage. Look, I have fed my mom. I'm with you, and I also want to say, I hope you guys understand that we here at CMS, we have family and friends and relatives in nursing homes too. It's not like we're sitting out here, in Baltimore saying, oh well, they'll have to deal with their family where we don't have any. It's not, we don't have a part. We have the same issues that you all have. But the role here is that while we encourage friends and family to visit and help, we also want to make sure that facilities are doing their part. And so we need, if you don't feel that there are, and there have been serious issues, then the first route is really to contact the state survey agency and make sure that they are aware that you believe that the facility is not doing their part. And then as visitation continues to open up and as facilities can have more visits, then yeah, I think that visitors that may or may not meet some definition of essential caregiver can go in and do what they previously were doing. It's a very complex issue. I hope I tried to explain a little bit from where it stands as a federal perspective, but also from an infection prevention perspective, and also from a legal perspective. So, but we understand that you guys feel pretty strongly about this, and there's not a lot of easy answers for it.
Sure. And I mean, we're gonna move on from the question just because of timing and because I think there's not much more. But I mean, I just do want to emphasize, because I know a lot of people listening, would agree, staffing, as we know, is always a problem. It has been a larger problem during the pandemic. And I think the concern from our perspective and from residents in facilities and from their family members is really that, as these vaccines become more available, as more and more people, and we know the numbers are very high right now, in facilities are vaccinated, the isolation and neglect is killing more people than COVID is. And so, I mean, that's why it's such a crucial issue to us. But to move on and shift gears a little bit, we have a question about outbreaks and facilities, which you addressed earlier. Our question pertains to staff, not residents, because we know the rates of vaccinations are much higher for residents. If a staff member tests positive, does that mean that visitation is shut down for the entire facility under the parameters you described earlier, assuming that this is a staff member who doesn't work in one specific area, but someone who helps people throughout the facility? Does that staff member testing positive constitute the outbreak and shut down visitation?
No, it shouldn't, because what should happen after that staff member tests positive is that the facility should do immediately one round of outbreak testing. And if they identify that, if the outbreak testing identifies no new cases, or perhaps cases are just isolated to one area, then the rest of the facility should be able to still have visits. You know, we specifically said the word area and unit, because units, I think, are most widely understood. CMS doesn't regulate units. We also don't regulate areas. We regulate facilities. But we think that units is a pretty universal word for facilities, that they can pretty much identify, okay, which units are infected or not. We also use the word area to recognize that, you know, we can't define something that fits into every way that a facility could be structured. You know, some have wings that fan out like spokes, some are buildings, some are floors, you know, some are circles, some are squares. We can't define all these areas. So what we're really trying to do is to make sure that there's some ability for stakeholders to understand that an area can be, does not necessarily need to be an explicit defined area with walls, but it can be an area that people can reasonably determine that the COVID cases are contained there, in that area, whatever that area may be, and they're nowhere in any other areas. And therefore, visitation can occur in those other areas. And that's what we're really trying to get at here, because if we stick to units, then we're afraid we'd be, I think an area, if a unit is super small, like 4 beds, that's that may be too tight, but an area, gives a little bit more ability to make sure that the virus is contained, and that there still is a good ability for visitation to occur.
Great. Okay. And our last question before I turn this over to Robin relates to quarantine. Under indoor visitation, one scenario where CMS suggests the facility should limit indoor visitation is when a resident is in quarantine, whether they're vaccinated or unvaccinated, until they've met the criteria for release from that quarantine. Mm-hmm. Among other things, we know that residents are going to be eager, those who can, to leave their facilities, to visit their loved ones, to spend the day or the night with their families. And we know that in some cases, this has led to quarantine upon return. The guidance doesn't speak to residents leaving and returning. It also doesn't appear to define when quarantine can or must occur. Should residents and families be concerned that if a resident leaves the facility, even if they're vaccinated and even if they're not exposed to anyone with COVID, they may be placed in quarantine for 14 days and unable to receive visitors during that time? And then does it matter if they're gone for more than 24 hours or whether or not they've been vaccinated?
Yeah, we definitely have been getting this question or not. And this is one that we're really going to leverage the experts at the CDC for, who are really, best suited for something that is really more on the infection control side of the fence. It's really, in their area. They did just release updated guidance, I think, which can be found on their website, which talks a little bit more about residents who need to be quarantined. And we do not say that anywhere that when residents need the facility, they need to be quarantined when they come back for 14 days. CMS does not have anything that says that. CDC has had suggestions, and I think we had a suggestion that it could be considered around the holiday times. In our holiday alert, we said that if you're gone for more than 24 hours, they should consider quarantine. But I think where we're really going to kind of come down on right now is that it's for individuals who have been exposed to someone with COVID, someone who's had a high risk exposure. Those are the individuals that may need to be quarantined, not just based on the mere fact that you left the facility. I think we're going to see more on this, so I'm going to stop there on this because I think this is really something that's more for the CDC, and I don't want I've learned I got to sometimes stay in my lane. There is more information on their website about this, and I think that what I can say though is that there is nothing at least that I'm aware of, that says that when a resident leaves a facility and comes back, that they automatically need to quarantine 14 days. I do have, I think you guys are going to close soon. There were a couple of other closing comments that I did want to make. I'm not sure if now's the right time or if you want me to do it.
Well, Robin was going to go next and talk a bit about our initial reactions to the guidance. So I think I can leave it to you to decide if you want to do that before she does that or not.
Evan, this is Robin. Maybe why don't you go ahead?
Okay, yeah, it's really just two quick things. Number one, we want to enable as much visitation as possible. I just want to remind everyone, we all have a role in this. Facilities have a role, CMS has a role, CDC has a role, and all of you have a role. We all need to continue to do our part to adhere to the core principles of infection prevention and control and prevent COVID from coming back and cases getting more. Again, I mentioned some things that are still yet to be determined, such as the variants and the ability for the vaccine to prevent transmission. So the point number one is that we all have a role. Point number two is we're not done. We think this is a great step, but we're not done. As CMS has gone throughout the pandemic, since our first visitation guidance back in last March, over the summer, a couple of times we had FAQs and other guidance that was released. Then we had our September guidance that was released that opened up visitation more. And then here we are today, after releasing the guidance on Wednesday. We're not putting this up and wringing our hands and saying, whew, glad that's over. We still have work to do, and we will continue to monitor the situation, monitor the evidence, and work with our federal partners and other stakeholders to find ways to increase and safely enable more visitation. So with that, Robin, I will turn it over to you.
Thanks, Evan. So obviously, since the guidance just came out a couple of days ago, we haven't been able to do a deep dive yet and thoroughly review and analyze it, what it says and what it doesn't say. But we did want to share with you just a few high-level kind of initial thoughts and reactions, just to get us started here. Next slide, please. So I guess, Evan, we want to start by thanking you and thanking your team and thanking everyone at CMS who contributed to changing the guidance. As both Jocelyn and Lori said, these changes are an important step in the right direction, and we think they will really make a tangible difference in the lives of many residents. I think that by eliminating a number of the restrictions that have been in place, this will really help reunite residents with their loved ones. So I just want to highlight two major changes that we're pleased to see. Next slide, please. And this ties back, obviously, to what Evan said and to the questions that Jocelyn mentioned and the points that came out from that. But first, we are very glad that when there's an outbreak or a county positivity rate over 10%, that will not shut visitation down for everyone. So we appreciate the fact that this has been more focused and more fine-tuned, if you will. And you'll see on the slide what that has been narrowed down to. So visitation will be limited only for some and not for all residents. So we are pleased to see that change. Next slide, please. And as Evan was talking about, we're also glad that if there's a confirmed case of COVID within the past 14 days, that's not going to automatically shut down all visitation. And instead, that based on what is found through outbreak testing, the suspension of visitation may be limited to a particular unit. So again, we feel that is more fine-tuned and more focused rather than applying the shutdown to everybody in the facility. Next slide. There are a few other positives I just wanted to mention very briefly. We were very pleased that visitation is not tied to vaccination for residents, with that one exception about county positivity and vaccination rates. We're also glad that visitors are not required to be vaccinated or tested for that matter. And along with Evan, we are very delighted that CMS has recognized the importance of a warm embrace between a resident and their loved one. We have heard so many residents and families who've told us that they thought they were really thinking that they would never be able to hug each other again. And so we're very, very glad that that is not the case. Next slide, please. So one family member who contacted us right after the guidance was released said, "This is a great step forward, but there's still a long way to go." And based on our preliminary review, we couldn't agree more. As I just pointed out, the revised guidance opens up more general visitation for more residents, and that indeed is a great step forward. At the same time, we do have some major concerns. Next slide, please. So these concerns are ones that you have heard discussed already during the questions that Jocelyn asked. So I don't want to belabor them, but we are concerned that the guidance does not permit the kind of visitation that will help many of the residents we think are suffering the most. And I'm referring here to essential support persons. We feel that there are residents who really need visitors who can provide the care and support that residents are not getting. So we are very disappointed that the guidance does not specifically establish this type of visitor, but we're also concerned that even without the establishment of an ESP, facilities are allowed to take actions that basically prevent families or others from providing that care. So for instance, facilities are allowed to schedule visits for a specific length of time. So that means that there would be no guarantee that the visit would be long enough to offer the care and support that a resident needs. And also, we're concerned that facilities are permitted to make seemingly arbitrary decisions about whether or not a resident qualifies for a compassionate care visit. And so as a result, far too many facilities are really routinely denying these visits. So that is a major concern. Next slide. We're also very concerned about enforcement for the reasons that came out in Jocelyn's questions and Evan's answers. The first reason, of course, is the word should, again. And also another reason is just the fact that from our observation and experience, we're seeing states and nursing home corporations and individual facilities being permitted to basically ignore the September guidance with seeming impunity. So in terms of enforcement, our essential our beginning assessment of the March 10th guidance is sort of the more things change, the more things stay the same. The guidance is again, filled with shoulds. And so we worry that once again, the CMS directives will be ignored. Surveyors will not cite facilities that deny visitation, and that weak or lack of enforcement will continue. Next slide, please. So where do we go from here? The next step that we at Consumer Voice will take is to do a deep dive into the visitation guidance. So we're going to identify the changes that have been made in more detail and evaluate what they mean for residents and their families. Once we've done that, we want to educate all of you about the revisions. So next slide, please. And we want to do that with a webinar to give you a more thorough and comprehensive understanding of the guidance, its impact on residents and families, and advocacy strategies. So be on the lookout next week for a notice about an upcoming webinar. We also want to educate and empower residents and families to use the guidance to advocate for visits. And of course, we're also going to assess where we are with our national advocacy. We want to get a sense of how this guidance is playing out in states and facilities, figure out what the gaps are, what the problems are, and then determine what we need to advocate for and how best to carry out that advocacy. Next slide. So stay tuned over the next few weeks as we share information and plans and strategies for those next steps. All of us, we, you, us, have to continue advocating until residents' full visitation rights are restored. I mentioned the family member who said that there is still a long way to go. That is true. But I believe that we will get there step by step, and that the March 10th revised guidance is one of those steps. The fact, I think, that we had to change our Take Action rally to an informational webinar is a positive sign. So let me say this. There are certainly numerous factors that resulted in the guidance revisions, but never doubt for one moment that the tremendous advocacy by families, ombudsmen, individual advocates, and state and national advocacy groups had a major impact and made a major difference. So I want to acknowledge the progress that all of us have made and say, as this slide says, yay, you. And while this guidance is just one step, it shows, I think, what the power of we can accomplish when we work together. Next slide, please. So we spoke up and we made our collective voices heard. Advocacy matters. Next slide, please. So in closing, I want to thank all of you on behalf of Consumer Voice for your hard work and effort. And now let's keep it up until those nursing home doors are fully open. So this ends the webinar. We're so glad you joined us, and we look forward to working with you until nursing home residents' rights to visitation are fully restored. Thank you and have a good rest of the day.